Hi, this is Dr. Bhargava. In this series, I have several interesting cases to share with you all. Let's start with a couple of chest x-rays. This patient had a frontal and lateral views of the chest, and here we can see that there is ill-defined fullness at the right hilum, and this projects over a vertebral body. Remember that vertebral bodies become less intense or more lucent as we go from superior to inferior, but here we have this ill-defined opacity. So the next step in this patient's management should be a CT of the chest. I tell the trainees to have a low threshold to ask for a CT of the chest when they see abnormal findings in the lung field. So this patient had a CT chest that shows this large spiculated mass in the superior segment of the right lower lobe of the lung, seen here in the soft tissue windows and also in the coronal image, which turned out to be a lung cancer. Here's a companion case. Again, the lung fields are predominantly clear except for this ill-defined opacity or fullness that is just superior to the left hilum. And so again, here the next step should be a follow-up CT chest, and this patient had a mass in the anterior aspect of the left upper lobe, seen right here, and also here in the lung windows, see the emphysematous changes from smoking, seen in both lung fields. Here's our next patient, and they had two views of the chest, and here there is a lucency that seems to be arising from the abdomen and going into the chest, and it also has an air fluid level, and so this is characteristic of a large hiatal hernia. Whenever you see lucency that overlaps the spine or the cardiac shadow, especially in the inferior aspect, most likely it's a hiatal hernia. A lateral view definitely helps, and if need be, you can confirm with the CT. All right, moving on to myocardial perfusion imaging. So this is a one-day protocol stress rest or rest stress myocardial perfusion imaging, where stress images are displayed on the top, the short axis, the vertical long axis, and the horizontal long axis images. As we go through the images, we find that there are no reversible or fixed myocardial perfusion defects. You will notice that towards the base in this region, the counts are missing in the infralateral wall, and that finding is worse on the resting images. And here we get a sense of, as we go more proximally, a focus of intense uptake of extracardiac activity that we also see here. And so when extracardiac activity is close to the myocardium, it can either contribute counts, that is called scatter artifact, or take away counts from the adjacent wall, which is called ramp filter artifact. And so probably that's what is happening here, because we see the counts being taken away from the infralateral wall towards the base of the left ventricle. Now, we established earlier that there is no ischemia. Let's look at the function. So here the ejection fraction is low. There was global hypokinesis on the gated images, which I do not have to show you. I do not have to share with you. And so with normal or no perfusion defects and abnormal function with low ejection fraction, we would make a diagnosis of non-ischemic cardiomyopathy. Here we have the rotating images or the raw data, and in a comparable projection where we have the better looking planar image, the stress image on the left, and the resting image on the right, and we can see this focus of extracardiac activity that is taking away counts worse on this resting image and causing this artifact that we saw earlier right there, counts that are missing from the infralateral wall towards the base. And so these rotating images confirm that there's a focus of extracardiac activity. This is uptake in the stomach. Stomach lies in this direction in this projection, and we see excretion from the liver into the gallbladder and some other small bowel activity. This is our next patient, and we have multiple views from CT of the chest showing a very dilated and distended esophagus, and it's tapering right there towards the GE junction. And here's the another view, sagittal, showing the tapering. And so this patient has ecclesiocardia, where there is narrowing at the GE junction and progressive distension and dilatation of the proximal esophagus. And what I've drawn on the image would look like the bird's beak or the rat tail appearance if we do a fluoroscopic study in this patient. Here is another patient, a middle-aged female who presented with progressive distension of her abdomen, and a CT scan of the abdomen and pelvis was performed with contrast, and you can see that the entire cavity is almost completely filled with this large cystic focus, which has some complexity. We see a septation here, another septation there, and there. And so this is a common finding in our practice, where middle-aged to older females would present with progressive distension, and we see the entire abdomen and pelvis filled with complex cystic mass. And MR, of course, is better at looking at malignant features in such complex cystic masses. But on the CT also, sometimes we are able to figure out whether this is more likely to be a benign versus a malignant ovarian tumor. Ovarian tumors commonly are surface epithelial tumors, and they present like this with complex cystic masses that distend the abdomen and pelvis. The suspicious features that we are looking for to diagnose malignancy would be multiple septa, thickening of the septa, mural nodules that show enhancement, and signs of metastatic disease such as lymphadenopathy, ascites, or carcinomatosis. This one turned out to be a mucinous cystadenoma, which is a benign tumor. Incidental finding frequently seen on the CT of the abdomen and pelvis, a fat attenuation focus peripherally in the liver, seen right here in the subdiaphragmatic and subcapsular location. This is called pseudolipoma of the Glisson's capsule, and no further imaging or intervention is needed. This is a benign finding. Here is a patient who presented with right upper quadrant abdominal pain, and a HIDA scan was performed to see if they have acute cholecystitis. And so as we look at the cine, we find that the liver takes up the radiopharmaceutical, excretes it into the small bowel. There is some excretion from the kidneys into the bladder as well. We see some infiltration at the site of injection in the left antecubital fossa. And as we follow the tracer, we find that there is a focal uptake right there where the cystic duct takes off from the CBD. And this is commonly seen when patients have a stone obstructing in the cystic duct, and there is radiopharmaceutical seen proximal to the duct where it joins the cystic duct, and that's called a Nubbin sign. And this patient has finding positive for acute cholecystitis, and there is obstruction right there, because when we compare to this patient's ultrasound, we find that the gallbladder is distended right there. There are some shadowing stones seen right there on the ultrasound. And look at the similar projection seen on the CT. The gallbladder is distended, and we have some dependent hyperdense stones. And we don't see anything like that here. We don't see any activity going into the gallbladder. So if I had to draw the gallbladder based on anatomic imaging, I would draw it like this, right? So the gallbladder does not show any activity, and that's because there is obstruction of the cystic duct from the stone right there, and we see a Nubbin sign from acute cholecystitis. This patient presented with a swelling, and sometimes that's the only indication, swelling or a mass. And what you want to remember from this case is that the finding may not be inside the abdomen, it may be in the abdominal wall. And so it makes it easier when I show you the corresponding three cross-sectional images. Here on the axial, we see encapsulated fat. Right here on the coronal and the sagittal, so this patient has an abdominal wall lipoma. This is our next patient, and here we see a finding which is similar to what we saw earlier on one of the cases, distended and dilated esophagus, narrowing towards the GE junction. Almost looks like the same patient with ecclesiocardia, except that more inferiorly, they have this gastric lap band which appears to be very tight right there. that is like the transition point and not allowing anything to go past it. And so it seems the patient got this gastric lap band placed, and it was recently tightened at another facility before they came to Houston to take a vacation, and it was too tight and it wouldn't let anything go past, and that's why we see this finding of distended and dilated esophagus. They presented with nausea, vomiting, and chest pain. And so the lap band is connected to this tubing, which goes to a port in the subcutaneous location, and the port is punctured, and saline was removed to make this less tight, and her symptoms were relieved. So this is one of the complications of lap band, which is it could be very tight, leading to distended and dilated esophagus with symptoms. Here is our next patient, and they underwent a CT of the abdomen and pelvis with both IV and oral contrast. And here we find the post-surgical changes in the abdominal wall. A hernia was repaired, and we see the hyperdense hernia mesh. Also seen here, it's usually linear and hyperdense. And we see a lot of small bowel loops that are abutting this region of the abdominal wall where there is extraluminal air. And also we see some contrast, and this finding of contrast extravasation, which is oral contrast extravasation, is very subtle. So you have to pay attention to the site where the small bowel loops are adherent to the abdominal wall. There is some extraluminal air and there is contrast extravasation. So this patient is developing a fistulous communication with the bowel loop and going to develop an enterocutaneous fistula. All right, so changing gears again, we have two set of images. One patient is here on the top and the other patient below. And these are images from an Amyvid PET CT. The scan on top at 3 different levels is showing uptake in the white matter only, and the gray-white differentiation is preserved, as we see here and here. But the images below show that there is uptake in both the gray matter and the white matter, and the gray-white differentiation is lost here, and at the most inferior level also. So the above one is a negative Amyvid PET, and the one below is positive for amyloid burden. So there you would diagnose Alzheimer's disease in the patients whose images are shown below. This patient presented with acute onset of pain after eating, and so there was a CT performed which shows that in the esophagus, so here is the trachea, left and right lobes of the thyroid, behind it would be the esophagus, and we see this hyperdensity that is horizontally lying in the esophagus, the upper esophagus, also seen here and here in the sagittal images. This was a swallowed fish bone that got stuck, and CT localized it, and we were able to evaluate the position, the size of it, to tell the gastroenterologist. They went in through the scope and they removed it. Here is an interesting finding. So frequently we learn the different enhancement characteristics of liver tumors on contrast enhanced studies in terms of enhancement and washout and things like that. And so if we look at this lesion here, which is shown on the MR, this is without contrast. I would call it C0. This is the arterial phase, portal venous phase, and delayed phase, and more delayed phase. And so this lesion near the dome of the liver does not show any arterial phase enhancement, shows enhancement and almost like a communication with one of the hepatic veins draining into the IVC, and the enhancement pattern is similar to that on all the sequences. So there was no place or no good image to show its communication with a portal venous branch, and so this is a vascular abnormality where a shunt has developed from a branch of the portal vein, and it's now draining into a branch of the hepatic vein and into the IVC. So it's a portosystemic shunt. And so these findings can be idiopathic and can be seen like this on cross-sectional imaging. This is a corresponding T2 weighted image showing high T2 signal in this focus. This is our next patient. Here we see patchy opacity in the right upper to mid lung zone, and again we performed a CT, and the CT shows consolidation, which is patchy, involving the right upper lobe, And so this finding is consistent with a pneumonia. These are images from a CT scan of the abdomen and pelvis performed in a young patient who presented after trauma, and we can see that the problem is in the right kidney. And whenever there are structures which are bilateral, always look at the other side to see what the normal looks like. So this is their left kidney, and look at the right kidney. There is this large hypodensity around it, so that's a hematoma. There are these linear structures that are going through that hematoma into the renal sinus. So these are lacerations, and so there are multiple lacerations in this kidney, and I'm pointing them out on all the different planes, and we don't see any contrast, IV contrast extravasation. But can we comment on urine extravasation? Probably not, because these images are only in the portal venous phase to evaluate whether there is extravasation of contrast that is excreted from the kidneys, which would suggest injury to the collecting system or the ureter. We want to wait and acquire more delayed images, which was not performed here. So with multiple lacerations and no evidence of IV contrast extravasation, and with the limitation that we cannot evaluate urinary extravasation, this would be a grade 3 or grade 4 injury. Here is another patient where we performed a CT of the abdomen and pelvis, and the finding is incidental and very interesting. Look at this region here, the right inguinal region. They have a hernia that contains fat and this linear structure inside with foci of air. So this is an appendix that is herniated into the right inguinal hernia, and that is called an Amian hernia. All right, single sagittal T2 weighted image from MRI of the pelvis, and here we see normal structures, T2 signal inside the urinary bladder. Here's the urethra, that's the rectum, and then we see the enlarged uterus. The endometrium looks okay, cervical canal, and the vagina going that way. The abnormal findings are these T2 hypointense foci. These are fibroids throughout the myometrium, and then there are T2 hyperintense foci, which suggest presence of endometrial tissue in the myometrium consistent with adenomyosis. So this patient's single sagittal T2 weighted image shows fibroids and adenomyosis. All right, so here we have a whole body rotating image from an FDG PET CT. It's FDG because we see intense uptake in the brain. And here on the rotating image, we find that there is hypermetabolic lymphadenopathy. And this hypermetabolic lymphadenopathy is predominantly in the left inguinal region, right, extending into the pelvis. There are some para-aortic retroperitoneal lymph nodes, probably a focus in the spleen, some nodes there, maybe a focus in the liver. Let's take a look at the rotating image again. Do you notice the asymmetry in the FDG activity in the lower extremities? The left lower extremity, the right lower extremity looks normal. We see soft tissue uptake, which is mild, similar to the torso and the upper extremity. But look at the left lower extremity. It is swollen and it is mildly hypermetabolic. And so what can cause that? In a patient with lymphoma who has large hypermetabolic lymphadenopathy in the left groin. So the answer here is that this lymphadenopathy is compressing on the veins that are draining the left lower extremity, leading to venous obstruction and swelling and hyperemia and increased FDG uptake or activity that we see here. So venous obstruction from lymphadenopathy, which we picked up on a rotating FDG PET CT image. All right, so this is our next patient. They have history of metastatic prostate cancer, and I would look at their bone scan and read it in this projection. So when we have widespread metastatic disease, it takes a pattern which is called superscan, and it may look normal if you are not looking at the right intensity. So here it is not the right intensity because the skull is not clearly seen, the lower extremities are not clearly seen. And when you crank up the intensity on your station, you will find that normal skull is seen, normal lower extremities are seen, but look what happens to the spine, the scapula, and the pelvis. This patient has widespread diffuse osteoblastic bone metastases, almost approaching a superscan pattern from prostate cancer metastases. Here's a representative sagittal image from the CT of the abdomen and pelvis, showing in the bone windows this diffuse sclerotic mets in the bones. All right, so that was the end of that series. I hope you enjoyed those cases. Thanks for watching.